Hi, my name is Catherine Varner, and I'm an emergency physician and clinician scientist at Mount Sinai Hospital and the University of Toronto in Toronto, Ontario, Canada. Today, I will be presenting our study entitled Emergency Department Use by Pregnant Women, a population-based study within a universal healthcare system. My co-authors and I have no conflicts of interest to disclose. I am funded by the Schwartz-Reisman Emergency Medicine Institute at Mount Sinai Hospital and the Department of Family and Community Medicine at the University of Toronto. Women interact more with healthcare services during pregnancy than at other times. In the United States, emergency department use during pregnancy has been reported to vary between 21% and 58%, with a higher frequency of repeat ED visits than seen among non-pregnant women. A limited number of studies suggest that emergency department use in pregnancy is associated with suboptimal antenatal care, psychosocial instability, and worse maternal and infant outcomes. These study populations consisted of commercially insured or low-income patients in the United States, who likely differ considerably from patients receiving care in Canada's universal healthcare system. Canadian pregnancy care is unique in North America, as antenatal care in first trimester is provided almost exclusively by a patient's family physician. In fact, the majority of pregnant patients will not see an obstetrical care provider until second or even third trimester of pregnancy. 20 years ago, nearly a third of pregnancies would be managed fully by a patient's family physician, including delivery. However, there has been a trend in Canada to specialization, and pregnancy care has also shifted away from primary care in the second and third trimesters. Now, only 3% of deliveries in Canada are attended by family physicians, yet how pregnant patients access care, particularly when complications arise, has not yet been rigorously studied. The aim of the current study was to quantify and characterize emergency department use among women in Ontario who had a recognized pregnancy, including by trimester and within 42 days after pregnancy. We also sought to stratify emergency department utilization by pregnancy outcome, including live birth, stillbirth, miscarriage, or induced abortion, as well as among women who had a threatened abortion and early pregnancy without a subsequent recognized pregnancy outcome. This study took place in Ontario using health administrative databases for the entire province, which are housed at the Institute for Clinical Evaluative Sciences. Ontario is Canada's most populous province and has a population of nearly 15 million people. We included all recognized pregnancies among Ontario residents aged 10 to 55 years, with an estimated date of conception between April 2002 and March 2017. Exclusion criteria included those without a valid Ontario Health Insurance Plan number, non-residents in Ontario at any point during the index peri-pregnancy period, duplicate live birth or stillbirth delivery records, as well as implausible maternal death date or implausible gestational age. The primary study outcome was peri-pregnancy use of the emergency department, namely an emergency department visit during pregnancy or up to 42 days postpartum, since this is the standard interval used to monitor women's health postpartum. We used modified Poisson regression with a robust error variance to generate relative risks and 95% confidence intervals for the outcome of any peri-pregnancy use of the emergency department in association with maternal characteristics. We also performed a dose-response analysis to evaluate the odds of a woman having 1, 2, or 3 or more ED visits in relation to trimester or postpartum emergency department use and pregnancy outcome. After applying the exclusion criteria, there were 2.75 million recognized pregnancies. 72% resulted in live births, 0.4% in stillbirths, 8% in miscarriage, 13.5% in an induced abortion, and 6% in a threatened abortion without a recognized pregnancy outcome. Our results showed that among the recognized pregnancies, nearly 1.1 million women, or 39.4%, had a peri-pregnancy emergency department visit. Furthermore, 1 in 4 pregnant women attending the emergency department had 3 or more unscheduled return visits. In terms of the timing of emergency department visits, among women with a live birth, emergency department use was most frequent in the first trimester, peaking between 6 and 8 weeks gestation, and then within the first week postpartum. The same pattern was seen for all emergency department visits, combining first and subsequent emergency department encounters. Although these are times during pregnancy outside of delivery that are higher risk for complications, these are also notably times when Canadian patients do not have access to their obstetrical care providers. For the patients who visited the emergency department, the most common diagnoses were early pregnancy complications, including threatened abortion, unspecified hemorrhage in early pregnancy, and spontaneous abortion. In addition, the rate of emergency department use was greater among women who had threatened abortion or miscarriage than among those who had stillbirth, live birth, or induced abortions. Our study identified several risk factors for emergency department use, such as younger age, being nulliparous, Canadian-born or long-term residents, having a lower income, living in a rural area, having a greater number of comorbidities, and being less likely to have an obstetrician. Our study also identified risk factors for multiple emergency department visits. Notably, women in rural areas were 3 times as likely to have 3 or more emergency department visits than those in urban areas. We also found that women with more medical and/or psychiatric comorbidity were more likely to have 3 or more emergency department visits compared to patients with minimal or no comorbidity. We acknowledge there were limitations to our study. Women who experienced a miscarriage but had no pregnancy-related healthcare visits would have been missed. Also, the outcome was unknown for women diagnosed with a threatened abortion or hemorrhage in early pregnancy, with no documented pregnancy outcome thereafter. As midwifery billings are not captured in OHIP, women whose pregnancy care, including an out-of-hospital birth that was provided entirely by a midwife, would have been excluded. Detailed data were also lacking about the acuity of a woman's condition at her emergency department presentation and the care resources and referrals on discharge. Lastly, there may have been clustering of women within hospitals where births occur. Even so, most hospitals in Ontario where there are deliveries do not rely on emergency departments for admission to labor and delivery units or for reassessment after delivery. Likewise, many emergency departments are located in hospitals without birthing facilities. In conclusion, more than 1 in 3 women in Ontario utilize the emergency department during their pregnancy or in the postpartum period. ED utilization peaked in the first trimester and in the first week after birth. 4 in 5 women with early pregnancy loss had an emergency department visit. Future research could inform efforts to streamline access to obstetrical care during peak times, such as the first trimester for miscarriage and early postpartum following a live birth delivery. I just want to take the opportunity to say thank you to my co-investigators for making this study possible and all of their hard work that they put into the study. And I also wanted to say thank you to SAME and the scientific committee for the opportunity to present this work, albeit virtually. And I hope that you all stay well amidst the COVID-19 pandemic.